Psychosocial Changes Part 2. Intimacy includes 5 major relational components: commitment, affective intimacy, cognitive intimacy, physical intimacy, and interdependence. It includes the need for close friendships, relationships with family and friends, spiritual connections, knowing that one matters in someone else's life, and the ability to form satisfying social relationships with others. It is an increasingly important factor in the care of older adults. Sexuality is a basic human need that goes beyond biological to include psychological, social, and moral dimensions. It includes more than intercourse. It expresses passion, affection, admiration, and loyalty. It enhances personal growth and communication and is an affirmation of life. This shows how sexuality is interrelated throughout our lives. The more sexually active a person is, the fewer changes that he or she is likely to experience in the pattern of sexual response as we age. Illness and medications can increase or decrease sexual response. The person's physical appearance may affect the person's security about their sexual attractiveness. Physical changes such as menopause does not mean that sex life has to end, and with men, a change in firmness of erection will occur. The nursing role is to provide education on these changes. Some illnesses, chronic illnesses that can affect sexual functioning include arthritis, cardiovascular disease, CVA, COPD, diabetes, and cancer. Dysfunction is often caused by an underlying medical diagnosis. Sexuality needs in long-term care facilities should be addressed. Long-term care facility residents have the same rights as non-institutionalized elders have to engage in or abstain from sexual activity. Aging family can evoke strong impressions of whatever an individual believes the typical family should be. Although relationship is often the most binding if it extends into late life, chances of a couple going through old age together is pretty slim. Roles can begin to change as the family ages, and we see changes in mental capacity of elders. We see elders and adult children relationships becoming strained because the younger adults are more concerned with their own spouses, partners, or children, or they might move away. Siblings can become particularly important when they're part of the support system, especially among the single or widowed elders that live alone. And other issues that change family roles can include divorce, widowhood, retirement, or becoming a caregiver or a recipient of care. This is how an 8-year-old child sees her grandmother. Mental health concerns can include isolation, where the client is alone and desires contact with others but is unable to make that contact. Grief, which is a reaction to the client's perception of loss, including physical, psychological, social, and spiritual aspects. Depression. The increased dependency that older adults may experience can lead to hopelessness, a lowered sense of self-control, and decreased self-esteem and self-worth. These changes can interfere with daily functioning and lead to depression. And suicide. Once again, all suicide threats from an older adult should be taken seriously. Remember that widows and widowers have had their social status affected. as well as their economic status and their self-image. Divorce in the elderly. Healthcare workers have to be concerned with supporting a client's decision to seek a divorce and with assisting him or her in seeking counseling in that transition. And retirement. The transitions are beginning to blur because numerous pursuits and opportunities can occur after one has retired. Many times you hear the elderly say after they've retired that they're busier now than they were before they retired. The numerous patterns and styles of retiring have produced more varied experiences in retirement. These are common widower bereavement reactions. Retirement planning, special considerations in retirement, and three-legged stool need to be considered in the self-perception, self-concept. Successful retirement adjustment has to be considered. These are the different phases of retirement. So as we age, roles and relationships begin to change, and people begin to ask the big question as to who they are. Roles and relationships can change by going from caregiver to the receiver of care, from working to being retired or disabled. Close-knit families are more aware of needs of the family members, and they tend to work to resolve the problems and find ways to meet the needs of the members, even if they're not always successful. The grieving process shows periods of grief. The first period is physical and psychological manifestations when grief is first felt. The second, we see exhibition of despair or depression, and this can affect daily function. The third period of grief is where the client begins to learn to adjust to the loss. Types of grief include anticipatory, acute grief, chronic grief, and disenfranchised grief. Those that cope effectively will maintain their composure, use good judgment, are optimistic without denying the loss, and those who cope ineffectively are more rigid and pessimistic. They're demanding, and they have emotional extremes. They might live alone, socialize little, and have few close friends. They could even have a history of mental illness and have guilt. Stages of dying or emotional reactions to dying include denial, anger, bargaining, depression, and finally, acceptance. The living dying interval. We have to realize that dying will begin at the moment called the crisis knowledge of death. In other words, when we know we're going to die, and it ends at the moment of physiological death. And the living dying interval is the time between these 2 points. Anticipatory grieving can occur with the dying time, but most of this time is spent in the chronic phase. The terminal phase of the dying time is when the speed of the physical dying is accelerated and the client no longer has the energy to maintain the activities of everyday life. Responses to death can include the person who is dying that may withdraw from outside work or engage in coded communication. They begin to give away cherished items or urgently contact friends and family. Dying in the nurse, we have to realize that the death of a client is not a failure of the nurse. Nurses provide safe comfort to the dying and gentle care to the family, and we have to be familiar with the grieving process. Nurses must have coping skills such as meaning making and the ability to disengage. In other words, You cannot let your emotional side completely, totally take over when you're taking care of a dying patient. You have to set that aside or disengage from the situation in order to be able to provide the appropriate care that is required from the client and the client's family. Nurses must be comfortable with their own lives in order to be able to deal with a dying client most effectively. Death is not the problem. It's dying that takes the work. This list of questions here are ones that the dying person frequently will ask themselves when facing imminent death. And then the 6 C's approach to end-of-life care. The first one is care. We need to encompass both physical and psychological care. Managing symptoms and support at all times, including pain management, psychological pain related to depression, anxiety, fear, etc. Medication alone is not going to relieve pain, and that pain will intensify when the psychological needs are not met. Sometimes knowing that just sitting with a person and using gentle touch is all that is required. And we need to assist the client with conserving their energy. The second C is control. We provide opportunities to feel in control, as one often feels like they no longer have control over their life. We provide choices and educate on the options so the person can make an educated decision regarding their care, and then we need to respect those decisions. Composure. Allow the client to have their sadness along with periods of relief. Communication. The type and content of communication will vary by culture. So make sure that they have the amount and type of communication that they desire. Continuity. Allow the client to live as normal as possible a life, as too often the dying feel shut off from the rest of the world. And closure. Anything which requires reconciliation and transcendence of the client. Also know that it is okay to cry with the family because it does show compassion, and the families will usually appreciate your compassion at this time.